Recording.
Okay.
Recording.
Anybody have any questions before I keep going? No? Okay. Yes?
No.
Okay. Back to skin infections. That's what we were talking about. We were almost done, I think. We already talked briefly about topical versus systemic. It is important with wound care and infections to talk about nutrition and the importance of protein and helping that infection start to heal and bring that good nutrients down to wherever that infection is, or whether that's a cellulitis or even just like a pretty good cut. That's something we can always touch on. Granted, we can touch on nutrition pretty much at every visit for every reason, but this is a good one as well. And then of course you always want to give guidelines when to call back or come back for follow-up. This is kind of an inpatient thing as far as interventions go. Again, we talked about nutrition just now. You want to maintain that IV access, make sure that your line is patent, you're checking the site. We're going to be giving antibiotics, probably fluids, as well as maybe some pain management for that. And then I put examples just as, what are some things that we can see infection-wise on the inpatient in a pediatric unit? Anybody have anything that they've seen so far in clinic? Nothing exciting. I would say pneumonia is kind of a frequent one at this point. We definitely want IV antibiotics for that. We're going to be giving fluids because chances are we're not going to be feeling super fabulous, and probably a little bit of pain management. If nothing else, it'll be, acetaminophen or ibuprofen for maybe some fever management, as well as just the discomfort of having that racking cough and the body aches, things like that. As far as outpatient goes for nursing interventions, it is all education, and then we are relying on, mom, grandma, whoever that would be, to be able to kind of go forth with everything that we give them. It is very helpful to give both verbal and written instructions, especially if English is not their first language. But even me, I realize that I will leave the office sometimes and I'll be like, wait, what did they say about this? So make sure that they have whatever that printed out. I know things like Epic give that to you automatically. When you discharge somebody, it prints it all out. And then you want to make sure that they really know when they're coming back. If this is a cellulitis kid and they need to come back in 3 days to have that area looked at again, it is helpful to just make that appointment before they even leave the office. Then they're going to get the reminder phone call and the reminder text and the reminder email and all those things so that they know how important it is to come back and be seen again. I put this back up here. This was from our last lecture where we did the fluid and electrolyte, but it's helpful to know these. These are medications that you need to know all of the things about. So acetaminophen, ibuprofen, you need to know the dosings for those. Remember what we can do as far as oral hydration when we are worried about fever, and then also about those alternative cooling measures. If you need to review this more, I suggest you go back and rewatch. I recorded this lecture, talked about it a little bit more, or go back to that F&E one. I did put this up here again just so you have it on your slides when they're printed out. Acetaminophen, 10 to 15 mg per kg every 4 to 6 hours. PO, they can actually give it IV now, rectal as well. Ibuprofen, 4 to 10 mg per kg every 6 hours. We certainly don't want to give that to infants under 6 months. And then you can discuss with parents that round-the-clock fever management, usually for only about 24 hours, just so you can see what the fever looks like at the end of that. I added on there this slide, this cultural and economic considerations. Definitely be concerned about language barriers when you're doing education about any sort of infection, whether that's discharge education or helping them understand what's going on. If they are coming in expecting an antibiotic and they're not getting it because it's viral, they're going to need a lot of education about that. Make sure whatever handout comes in that primary language. And make sure that they are verbally telling you they understand, and not just nodding and saying yes. Sometimes I'll ask questions like, oh, okay, so what are you going to do first thing when you get home, or questions like that to make sure that they really understand it. I think I put in the video too, but Marshallese and a lot of times Hispanics, people of Hispanic descent, will just nod and say yes, even if they don't understand everything that you're saying, whether it's cultural or, they just want to get out of the office. Who knows? I think that it's usually that they understand a good part of it. They just may not understand all of it. So that's why it's important. Definitely make sure you're using a translator if English is not their first language. They should be, pretty much any office should have that now, that where you can call and have somebody make sure that they understand what's going on. And then of course, chart it. Make sure you let, future whoever's looking at this patient's chart know that you did talk about this specific thing with them and you did use a translator. So when they come back in and say, well, I didn't know I was supposed to do that, you can show that, yeah, you did tell them, and it's your license that you're protecting. So it's important to do that. Before you discharge or leave the appointment, you want to make sure that they are able to get the medication if they are being prescribed something. A lot of times their insurance doesn't cover something that is more expensive and or even just done at a hospital pharmacy. So you want to check and make sure that they're going to be able to pick that medication up, because you don't want to send them home without it. Evaluation of the care plan. Of course, we want to make sure that infection is gone. We're not having any crazy long-lasting symptoms, right? We can still have a cough sometimes after the worst of something is gone. Your average cough actually lasts 21 days. So, helping to educate on that too. Like, yeah, you may not have fever anymore. Your runny nose is probably better. But if you have that lingering cough, that's okay, as long as we're not having a fever and as long as it's improving. And then of course, we want them to discharge if they're in the hospital. That's part of our care plan. Did they get out of here? And then when they're going to follow up with their PCP, when they're going to be seen again. So here is our first exemplar. This is acute otitis media, or AOM, because that is easier for me to say. Nice, really fun picture there of that redness and it looking not very happy inside. So otitis media itself is inflammation of the middle ear with some fluid present. Acute otitis media is actually the ear infection itself, and that's almost always going to be secondary to some sort of upper respiratory infection. You can get acute otitis media from having allergies, things like that can cause it, but again, it's still going to be the same thing. You're going to have those other symptoms before the fluid gets stuck in there and starts having stuff grow inside it. It can be bacterial or viral. Sometimes it could be both. Again, a lot of times it's going to start viral and it's going to end up growing some nasty stuff on top of that. Viral causes are always going to get better on their own. So they still may be miserable for a day or two, maybe even 3, but they are going to start to improve on their own. And then I just listed some of the most common bacterial causes for AOM. Infants are more susceptible. They are most at risk here. It is because they have those immature immune systems, which we already talked about. And then their eustachian tube is shorter and a little bit straighter. That's why when we are assessing adults versus children and infants, we are going to pull their ear out differently so we can see. It is a generalized rule. There are times where you are pulling all over the place because somebody has, an interesting canal, but generally speaking, they're going to follow that adult versus kid way. The eustachian tube's job is to equalize the middle ear pressure. Obviously it cannot do that if it is blocked. Usually that is by all of that mucus. Another reason that infants and children are more susceptible, they have an increased size of their adenoids in relation to grown-ups. And if those are enlarged due to infection, because they hold all of those great lymphocytes in them, it can end up blocking your eustachian tubes. So some risk factors for AOM, like I said, allergies, any sort of craniofacial abnormalities. Having a smoker in the house makes a huge difference for people who are frequent AOM, kids who have it frequently. Getting mom, dad, whoever to be smoking outside is a step in the right direction, but it's still, that smoke still follows them. And if they're holding that baby, that has been shown to be a huge risk factor. Exposure to group daycare, of course, because they're going to be, around all the other sickies. If the family history is recurrent of AOM, if they have GERD, any sort of immunodeficiency issues. Breastfeeding babies have a lower risk of AOM than those who are bottle feeding. I did mention bottle propping in the recorded lecture. That is a big, huge no-no. So anytime you have an infant coming in for well child check or anything, and they are bottle fed, you want to make sure that that mom and dad and whoever's feeding baby knows that that is a huge no-no and can actually cause choking and all the sorts of other things. I did add this bold part in here just so you see. Feeding while laying flat or prone can totally increase the risks. So if you send even a 2-year-old to bed with the bottle to have them fall asleep, A, that's going to increase their risk of AOM, and B, it is going to ruin their teeth, because we should always, at least, even if we're not brushing, we should be wiping off those new little teeth with just a gauze and some water or something to kind of get some of those sugars from the milk off. Pacifier use is on there, and then of course upper respiratory tract infections is going to, if you have one of those, you're going to have a higher risk for AOM. So signs and symptoms, you have, just your regular old URI symptoms. That's, runny nose, your nose is congestion, you have a cough, you have a fever, you feel terrible and miserable. Infants and children, I have listed both on here. A lot of it's really similar, tugging or pulling on your ears, rolling your head kind of side to side because you're just uncomfortable, not eating well, not drinking well, fussy, irritable, things like that. And then of course at the bottom I have is drainage for both of them. If you've got drainage coming out of their ear, then we have AOM, and it means that we have perforated our eardrum. So assessment, as far as AOM goes, we're going to still ask our old carts, we're going to still ask our news, we're going to look and see how this kiddo is behaving, and then we want to look at what systems are we assessing, right? Typically, if you're doing anything in HENT, you're just going to do the whole thing. There's no point in looking in just the eyes and then not also looking in our ears or looking in our mouth, because those things are all kind of connected in themselves. But if you're coming in with the upper respiratory infection symptoms, I am most certainly going to be checking heart and lungs anyways. I do that with everybody. And I might throw in a quick GI exam as well. You can have postnasal drip that can cause some stomach stuff, and you're already in that vicinity. If the kid's going to let you do it, it's not going to hurt. As far as infant pediatric ear exams go, there are two things to be concerned about. One would be safety, and the other would be tolerance. Usually when you have a kiddo that's really, really sick, it's hard enough to get any exam done without them throwing a huge temper tantrum. They do not like you. They do not want you near them. They don't want you touching them. And if they are jerking around and fighting you, putting that little tip from the otoscope into their ear is not the best life decision. And then also, again, they're less likely to tolerate that ear exam more than once. Check with your provider, of course, but I would leave that to the provider. You do what you can for your nursing exam, but I would leave actually looking at the ears to the provider, just so that we're not using that one shot we have before the kid realizes how miserable this is and doesn't want to do it again. There aren't really any diagnostics you can do. Your diagnosis for AOM is going to come from what the history is, right? We were in daycare, we've had an upper respiratory infection for 3 days, it's increased to the kids pulling on their ear, they have a fever, and then the provider is going to go in and look and say, oh yeah, that's definitely an infected, ear. So that's what you're going to get your diagnosis from as far as this is concerned. First line treatment, what we typically like to use is a high dose amoxicillin. So that's 80 to 90 mg per kg per day divided into 2 doses. If we have had recent antibiotics, or we think that we're going to be resistant, we're going to give amoxicillin clavulanate, and I have that dose there as well. I believe that amoxicillin is something that you guys have seen before or have had before as a medication to know. This is a big one. You're going to give amoxicillin for a ton of different things, so know the pharmacology of this one, know the side effects, know why you're giving it, be familiar with the dosing, probably both for peds and adults, though of course only for this class we really need to know for peds as far as that's concerned. If we have allergies to penicillins, then these are your alternative treatments here that I listed below. Again, be familiar with them. I don't need you to be able to spout that stuff off, but you should know the basics and at least like red flag symptoms if they're not tolerating it. This is a very helpful thing. I stole this from the book as well. It is ultimately going to be up to the provider if they're going to give antibiotics or choose to observe for a few days. But having this as a good guidance can help parents too. When they're not real happy that their poor miserable child is not getting antibiotics, this is a good thing that you can show them that, this is kind of what's been proven. This is page 1453 in your book, because I didn't know if that made it onto your guys' reading, so I put that in there for you. As far as a care plan goes, I can't imagine anybody having AOM and needing to be hospitalized for that, so I threw outpatient in there just so you know. nursing diagnosis, I picked acute pain. We all know ear infections are miserable and feel terrible. So we want to provide education about pain medication for parents and look at non-pharmacological methods for that pain. And that includes distraction, maybe warm packs for their ear. We want to make sure that we talk about with mom and dad how hot is too hot, how position changes can help. Sometimes having that bad ear down can help it feel like it's getting a little bit better. Sometimes it's the opposite. Another nursing diagnosis I picked was risk for impaired hearing. If we have kiddos that are on repeat AOMs, we want to start being careful about that, because especially when we're young and we're still developing, we want to make sure that they're not having any issues with that. So talk about risk factors, prevention. If we're having this frequently, we're coming in, we can find out if they are in fact, putting kiddo to bed with a bottle, things like that. And then also those age appropriate hearing checks at well child checks. Evaluation for our short-term goal, we're going to make sure that we are not as uncomfortable, and then those other symptoms are going to be a little bit better, right? We're going to be taking more fluids, we're going to be a little bit perkier, we're going to be eating again, fever is going to go down, things like that. Long-term goal is going to be, of course, the resolution. I didn't put that on there, but and then prevention of that repeat infection, education, and continuing those hearing screenings. Evaluation of all of this, our patients back to normal, right? They were where they were before, and we didn't have any issues with our hearing or long-term issues. A few special considerations I put in just to be aware of. Perforation in the tympanic membrane is when that pressure is so much that a little like tear or hole gets put in the tympanic membrane. And that's when you can see any sort of drainage or oozing coming out from the ear. This happened to my second youngest nephew when I was staying with my sister, and that kid was screaming. I think he was like 15 to 18 months, screaming. And then all of a sudden he just stopped, and he kind of had like this little smile on his face. And parents may say that because whatever that horrible feeling of pressure was just magically gone. And I looked over, and let me tell you, it was gobs and gobs of what looked like snot coming out of his ear. So he felt a lot better, but we're going to want to treat that a little bit differently too. And then ear tubes, those who are having frequent ear infections, we will send to usually a pediatric ENT or ear, nose, throat specialist, and they put tubes in that basically keep the pressure equalized so that we're not having any risk of that. The tube is designed to keep this eustachian tube open, that's all. And then if you still end up with that, you can do a topical antibiotic because it's going to deliver it directly. So second exemplar, tonsillitis. I tried really hard to find the grossest pictures I could, so you're welcome, guys. So pharyngitis or tonsillitis is inflammation of the pharynx or the inflammation of the tonsils. This can be viral or bacterial. Of course, if it's viral, it's self-limited. It's going to go away on its own. And commonly, if it is bacterial, it is going to be that group A strep. So we are most common in preschool age to about mid-teens. Some of our most common symptoms that we're going to be seeing: red swollen tonsils, white yellow patches on the back. That exudate usually looks pretty gross. They're going to come on with complaints of sore throat. It's going to be hard to swallow. It's going to be difficult. They're going to have a fever. Usually we're going to have those enlarged tender glands in their neck. Sometimes you get that scratchy voice. A lot of times it definitely is muffled because you can tell how swollen it is. Bad breath is normal. Stomach ache is some neck pain or stiffness, and then headache as well. When you got little kids, a lot of times they're going to be drooling because they don't want to swallow. They're not really going to be eating, and they're definitely going to be a lot fussier than they are normally. So as far as assessment goes, old carts, everybody's favorite: onset, location, duration, characteristics, aggravating and relieving factors, treatment, and severity. Our news, nutrition, and elimination, whether they went to work or school, and how they are sleeping. Look at their appearance and behaviors again. Most of the time, they're not going to be happy-go-lucky if they've got strep throat. As far as systems that we're assessing, it's going to be one above and one below again. We're still in this HENT area, so we're going to do all of that and then add in our heart and our lungs. And then it is important to be paying attention to what our tonsils look like. So they have stages 1 through 4. 1 is when they're nice and boring and normal. 4 is when they are kissing and they are touching each other. And that is definitely when you're going to hear, their voice sounds like it's really swollen or it's muffled. You want to look for any sort of uneven swelling in the back. A peritonsillar abscess is a huge deal. That is an emergent thing that you send somebody away for, or if you're in the emergency room that you're going to get like an ENT or a surgical consult on. You may have that exudate on the tonsils, like I said, that white patchiness, and it's possible also to have basically what's called the strep rash or scarlet fever, which is that sandpaper rash on the trunk and the abdomen all over. And I did add a picture of that towards the end here, but you can Google it and see if you can see what that looks like. And then of course those enlarged nodes. And then I put this on here, like I said, in the recorded lecture, because I searched for kissing tonsils to see if I could find you a picture, and it gave me this weird stuffed animal. So you're welcome. Diagnostics for tonsillitis, which, you know, we're usually looking at with the consideration that it's going to be strep. So there's that rapid throat swab, and then we're going to do a culture at the same time. If you have to put those itty bitty things back there and make people gag and miserable, you may as well do it at the same time. Strep can technically be diagnosed based on history and exam. You know, if you know that older brother and little sister both have it, and we've got fever for 2 days now and sore throat and difficulty swallowing, and you see exudate on the tonsils, things like that, we're going to basically treat empirically regardless. But it's good to still have that culture so we can make sure that it's the same kind of bug that, you know, sister and brother had as well. So as far as treatment goes, I have this whole little fancy thing here as far as kind of how you decide what you're doing with strep patients or those who come in with a sore throat. I have pointed this out before, but I'm going to do it again. You rarely have a cough and also have strep throat. So when somebody comes in and says, I think I have strep throat, I am coughing and my throat's sore and I have a runny nose and I have a headache, chances are it's not strep. I have seen it, but it is, I would say, out of every 15 strep cases I've seen, maybe one had a mild cough. And usually that was because they had something else as well. I did have a poor patient who had not only influenza A, but also strep throat at the same time. Not fun. Antibiotic treatment, look at that, it's amoxicillin again, guys. You can see it is a little bit of a lower dose. That is because it is more, it can get to the throat area, or it can get to that more easily, whereas you have that higher dose in AOM because it's harder to get into all of that gunk in the inner ear. An alternative treatment for strep would be like a Z-Pak, or in kiddo speak, that's 12 mg per kg per day times 5 days. As far as the care plan goes, these are the nursing diagnoses I chose. There are obviously other choices. Risk for fluid volume deficit. If we are not wanting to swallow because our throat hurts so badly, chances are we are not going to be drinking anything, right? So talk to mom and dad, hey, this is how much they need to be drinking. You know, be watching their output. We want to make sure that they're either having enough wet diapers, or they're using the bathroom enough. Talk about small sips, popsicles, and encouraging, if they're going to be eating, you want to have like high water content foods, because that's going to help keep them hydrated as well. I would stay away from dairy unless that's all the kid wants, because dairy can actually coat your throat and kind of make it harder to swallow, in which case they're not going to want to continue drinking. And or we would be concerned about, you know, losing some fluids if we're just drooling consistently. Another nursing diagnosis could be risk for treatment plan non-compliance. Hey, little Timmy is feeling so much better after 4 days of antibiotics, and he's not going to take the rest of it in his 10-day course. So we want to make sure that we're talking to mom and dad, grandma, grandpa, whoever it is, about making sure to take all of those. And then, you know, it also helps to talk about how we can get them to take these antibiotics when they maybe don't taste very delicious. And I know we talked about this last time, but you can put little bits in applesauce or little bits in something like yogurt. Of course, that's dairy, but if that's what the kid's going to take, that's fine. Just make sure we're not squirting the entire syringe into an applesauce packet that little Timmy then decides he does not want to eat at all. And then discuss when we're coming back, and then those red flag symptoms, right? If they are actually unable to swallow, if it looks like, you know, one side of their throat's far more swollen than the other, those are things that we want to come back for. Evaluation on our short-term goals. We want to feel a lot better. We want our fever to go down. We want to make sure that we have a good airway, right? That's probably the most important. And then we also have, good hydration status. We're not dehydrated. We're able to take those sips and keep that fluid in, and make sure mom and dad understand what we're doing. Long-term goals, we want to make sure we do all of those antibiotics, finish that whole course, and prevent the spread of infection, right? Especially if we have lots of siblings or we live with cousins, things like that. 24 hours after you begin antibiotics, you need to throw your toothbrush away, and you need to be on antibiotics for 24 hours before you can return to school, because we do not want anybody else to get it. Again, this is kind of a pre-COVID thing, since most people aren't in school right now. Evaluation of our care plan. Did we return to baseline? Are we eating and drinking normally? Are we playing? All of those things. I threw this in here. This slide was not in the recorded lecture, so keep that in mind. I know you guys probably printed these out ahead of time. So if, and I put the page numbers in here as well if you want to go read that in your book. If you are having super frequent tonsillitis or strep throat, if you have that strep greater than or equal to 7 episodes in 1 year, or greater than or equal to 5 in 2 consecutive years, they will consider taking your tonsils out. It does not mean that you can't get strep throat, but it definitely decreases that risk significantly. Post-surgery, which I think you guys have seen maybe this in clinical so far, they do the TNA, the tonsillectomy and adenoidectomy. You want to make sure that your airway is patent. I mean, that's for everybody, right? But super important. Want to make sure that we're not having any post-surgical hemorrhage, and we're going to be, also really concerned about pain management, and also that they're getting hydration. A lot of times they're going to have an IV for that, but they want them to start, having sips and popsicles pretty soon afterwards. Things to be aware of or watch for would be a bunch of bright red bloody secretions. A little bit of mucus tinged, or mucus with a little bit of blood is okay. You don't want frequent throat clearing. If they're over and over and over again, that's kind of a red flag. If our heart rate's going up a bunch, if we're really pale, if we seem really restless, those are things to be pretty concerned about. And if we are throwing up bright red blood, again, that is a big no-no. So we need to have that reevaluated by either a provider or the surgeon almost immediately. I was able to go in, I think 2 weeks ago, and do some of the simulations with a few of the students, and I let them know this was my favorite thing that I learned in pediatrics, which is every single day when you get your patient assignment, and this works for not just pediatrics too, of course, you should look at each of your patients and say, what is the worst thing that could happen to this patient, and then be prepared for it. So in the case of, tonsillectomy, the worst thing that could happen would be this hemorrhage, right? So when you look at that patient room, you go in for your first assessment, you want to make sure you have everything available for you to take care of the patient if the worst thing that could happen, right? You have a soft suction on the wall, you have your ambu bag hooked up, you have the surgeon's number on hand, all of those things that you are ready to take care of the patient. I put mini exemplar because I did not do this one quite as in depth as I did the others, but I felt like cellulitis was pretty important. Even in inpatient, you get that a lot. They end up needing IV antibiotics because it's actually that big of a deal. And I had to put Dr. Evil on here because every time I hear mini something, I can totally imagine him putting his pinky to his lip and saying that. So cellulitis is an infection of the skin or the underlying tissue. It can be caused by lots of different things. I put 3 very common ones on here. There are obviously other choices. Insect bites that kids are scratching a whole bunch, a lot of times can get more infected. Of course, we have lots of germs underneath our fingernails, so that can get infected easily. We have folliculitis or impetigo, which is a very common pediatric diagnosis as well. Cellulitis is going to be categorized by having erythema, pain, swelling, and warmth at the site. As far as diagnosis and treatment goes, a basic skin infection, we're not going to need to do anything. We're not going to, aspirate some sort of wound and see if we can get something out of it. But if we see something, right, or if that little head or that pimple at the top is draining, we can do the wound culture and send that off. It can help us see these are some of the more common bugs that you can get. I put just brief treatment on here. Cephalexin is a pretty standard skin infection one. It is also a lot of times what they give in in pre-op for anything before they cut in. A lot of times they give just this one dose before first cut. And then as far as a skin treatment goes, Upiricin is a good one that can cover most things that we're going to find on the skin. Some non-pharmacological treatment, like I talked about before, you want to trace wherever that red or raised area is with an appropriate marker, and then talk about with mom and dad, you know, aunt, uncle, whoever is taking care of them, when to return. You know, hey, if this goes past this, you know, after we start antibiotics, after 24 hours, you need to come back so we can see you again. It means that your antibiotics aren't working. Warm, wet compresses a couple times a day can really help. Again, you want to make sure that the temperature is going to be appropriate. You know, help mom and dad figure out what that is. Make sure we are not picking at popping whatever it is or messing with it, especially if we're not already open skin. We certainly don't want to open that for no reason. If kids are having a hard time, especially during sleep, you can put socks on their hands. You can still scratch at night, but it's not as easy, and you're less likely to like have nails catch on things that open up the skin. If you do have drainage, you want to keep it warm and dry. You're going to want to be able to go over that with mom and dad. Like, hey, this is what the provider said, you know, we want you to do, clean it out this much, you know, this many times a day with normal saline, or, you know, just change the gauze. Maybe this is when you're going to put the Upiricin on. And that'll kind of be based off of what your provider says. Here is a picture of cellulitis. You can see that it is not necessarily well demarcated borders, but you can tell it's definitely red. You can just imagine touching that, how that skin will feel hot and probably super uncomfortable. It's definitely a little bit swollen. So cellulitis nursing care plan. Diagnosis I have, risk for impaired skin integrity, right? We could open it up. We could have all sorts of things going on in there. Talk about all of that with mom and dad, education, following the care plan, right? Our medication, whatever we're choosing. It has been helpful at times to talk about circulation with mom and dad. Obviously, you kind of got to gauge what their abilities are and what their level is. But I've had plenty of parents that I can actually be able to say, hey, you know, like make sure that below this area, say in the picture before that example, you know, hey, we want you to be touching her foot regularly. Make sure that that feels as warm, and even show them, you know, how to check for cap refill. Hey, if this goes greater than, you know, you counting to this, then we need a phone call back. And then talk about, of course, adequate hydration, nutrition. Like we said before, that increased protein makes a big, huge difference with things like cellulitis and skin infections. A second nursing diagnosis I picked out was impaired physical mobility. Again, talk about the importance of the care plan. And then we don't want you just sitting around doing nothing, because it's going to feel worse when it comes time to actually walk on it, right? Or do something. So talk about gentle range of motion, you know, as we're able, depending on what limit is, make sure that the rest of our body isn't just laying doing nothing. And then talk about some alternative activities, you know, especially if you've got a little 5-year-old who wants to bounce around all the time and do stuff, he is going to have a hard time sitting still. We want him to rest. We want that leg to get, you know, healing. We want things like that, but we got to come up with something else for him to do, because he's going to be bored out of his mind. What time is it here? So we have time if you guys want to take a quick break. It's up to you. It is kind of a longer case study. If you guys want to take 5 minutes, we can. Otherwise, we can plow through. It's kind of up to you guys. Anybody need to use the bathroom, fill our water bottle?
Can I make a small statement?
Sure, of course.
Two actually.
Yeah, go for it.
Two actually. Is anyone in this class trying to call my office? No.
Nope.
Okay. Somebody has tried to call my office 10 times in the past 5 minutes with some strange number, and it won't let me call them back. So I was worried it was one of you guys trying to get a hold of me for some reason. The other thing is, just a reminder that this does have to go up on YouTube. So during the case study, if you don't feel comfortable showing your face, we completely understand that. Like normally we ask you to turn on your camera so we can see you, but because I'm going to have to put this up on YouTube, if you don't feel comfortable with that, that's completely fine with us. And also, so you know, it will only be up until the test is over. Once the test is done for this material, I will make that video private and no one can see it. I'll hide it. Okay. So it's not like it's going to be there forever. Just to make everybody feel better. about it. All right. Are you guys taking a break right now, Rachel?
I was waiting to see if anybody needed to. Like I said, I wanted to give them a chance before the case study, but if nobody needs to, I can go forward.
Okay.
I just figured I would kind of check in. I know we had a mini one before.
Okay. Do you guys need a break?
I'm good.
I think we're fine. I will say,
okay.
I just saw in a chat, I saw somebody sent a question about dosage for the amoxicillin clavulanate, and that is the dose. It's listed as 90/6.4. That's because the dose of the amoxicillin is the 90 mg per kg, and then the clavulanate is the 6.4 mg per kg. So when you look at that, when you have a medication like that, it's because it's combined and it's telling you how much of each one that you've got on there. So that was a good question. Thank you for asking.
So for those of you who are in the clinical setting and been in the clinical setting, what she's talking about is Augmentin. That's we won't ask you about that, but I'm sure you've given it before. We give it to adults for upper respiratory stuff.
And probably taken it yourself.
Probably. Were you talking about tonsillitis or ear infections?
Yes.
Yeah. Yeah. That's what we give for stuff up here. So it's written the same for adults as well. Obviously it's just not weight based.
Yeah.
But it should not be a new drug to you guys. All right, so you're going to continue to go. I was just going to pause it, but if you're going to continue to go.
Yeah, it sounds like we're good to go. So
okay,
I'm going to keep going. We'll go back to our case study. Okay, so infection case study. So Charlie is a 30-month female who presents at urgent care today where you work. It is 9:30 in the morning, and her chief complaint is ear infection. Which is not, there we go. There's poor little Charlie. She is here today with her mother, and you are triaging her. You brought her to the room. So what questions are we asking?
History.
When did the symptoms start?
Yep, absolutely. What specific things are we going to be asking for her?
Has she ever had an ear infection before?
Yep, that's true. Think about the slides that I have that as far as history goes. What is that lovely acronym that we want to use?
Old carts and news.
Yes, old carts and news. That's what we want to know because that gives us all the information we need to know. So I have this all listed for you here on the screen. I will go through it briefly. Onset, Charlie began having a runny nose about 5 days ago. She then developed a mild cough, and 2 days ago, she began to pull and tug on her left ear. Location, runny nose, of course, that cough and that left ear pain. Duration, her ear pain seems to be intermittent, but that runny nose is constant. Cough is every once in a while. Characteristics, she has thick green nasal discharge. Her cough is congested. She has a Tmax of 100.5 this morning, taken axillary. All of her symptoms seem to be exacerbated with activity. That's an aggravating thing. Relieving, she seems to have some improvement with Tylenol as far as pain goes, but it doesn't change anything else. Her last dose of Tylenol was at 8 o'clock this morning. Treatment, she's just had those over-the-counter pain meds, and she's had some warm pack for her ears. As far as severity, mom says this doesn't seem as bad as last time, which of course is when you can say, oh, has this happened before? Or when was the last time? Which per mom was about 6 months ago. Nutrition, she has a decreased appetite, but she is drinking fluids well. She's taking Pedialyte and some half-strength juice. No changes in her voiding or stooling. She's potty trained. That all seems fine. She does not attend daycare, but her older brother, who is 5 years old, plays soccer. They do not go to in-person school or preschool, but brother did wake up with a fever this morning, complaints of sore throat. He is in the waiting room with his dad. And as far as sleep goes, she's been kind of interrupted off and on for the last 3 days or so just because of that runny nose. Here are her vitals as listed. Heart rate 125, respiratory rate 30. O2 is 98% on room air. She has 82/55 on the right leg. She wasn't real happy you took her temperature or her blood pressure, but she did okay. And we have a 99.5 temporal. Okay, so I have what systems we need to assess on Charlie, right? And I will pop up. This is what it looks like for her. She is awake, alert, fearful of her staff. Her eyes square as white, no drainage, perla. You're not going to do her ear thing, right? We're going to wait and let the provider do that. She's got thick, bright green drainage, septum's midline. We're not able to see those turbinates through all of that drainage. Tongue is midline. She has some moderate erythema to her pharynx in that back area. Tonsils look to be 2+ bilaterally, and her teeth look okay for her age. Mildly enlarged cervical and sublingual lymph nodes. Lungs are clear throughout, equal and bilateral chest rise. Heart rate is regular, no murmurs. Cap refills good. Pulses are 2+ in all extremities. And we did GI on her as well. Bowel tones ×4, soft, non-tender, and non-distended. So what do we need to do as far as diagnostics go for Charlie? Is there anything we could do for her?
Throat culture?
We could, but if she's here for complaints of ear stuff, at this point we can say, let's hold off, right? Because even though brother's here with a sore throat, we're not really sure if she's complaining of that. She's really concerned about her ear right now. So give me 2 nursing diagnoses for Charlie. I'm going to start randomly calling on people.
Acute pain
Pain.
Perfect. Great. What's another one?
Risk for impaired
and
hearing.
impaired hearing.
Excellent. I put risk for dehydration in relation to fever too, just because she has the fever, right? That's what we got from that last lecture. And then what are some interventions that we can do for Charlie right now? Nursing interventions.
Pain meds.
Mm-hmm. What are we going to want to give her as far as pain meds?
Tylenol.
Acetaminophen.
So that is a great choice, except mom already told us that Charlie had Tylenol last this morning at 8 o'clock and it was only 9:30.
Ibuprofen.
Ibuprofen because you're older than 6 months.
Yep. Perfect. So get your order from your provider for your ibuprofen. Make sure we don't have that ear pain. We can offer a warm compress for mom while we're there. And then you can talk to her about the temperature, make sure that it's not too hot. And then we can give, Popsicle, Pedialyte, something like that. Usually you're going to have those in the clinic setting. So now that you've given a report to the provider assigned to Charlie, this is Dr. Smith, you're going to go into your next room. Chart states this is a 5-year-old with complaints of fever and sore throat. Patient's name is Ryan, and you find out he is Charlie's brother. He is here with dad. So what questions are we going to ask Ryan's dad?
Old Carson News.
Yay! See, I'll get this stuck in your brain, I promise. Okay, so here's what we have for Ryan. Sore throat began last night before bedtime. He did have a fever this morning. It was 101.3 axillary. He has had some complaints of sore throat, no cough, runny nose, ear pain, nothing like that. It is definitely a constant pain. He himself, because he's 5 and can tell us these things, tells us that his throat feels very pokey and like it's really hot and on fire. Swallowing is what makes it worse. He says nothing has made it feel better. He also had Tylenol this morning at 7 a.m., but has had no other treatments for that. And as far as severity, we're 5. So he says it's really, really bad. You show him that pain chart, chances are he's going to give you that 10 on the pain scale, or sometimes they do 5 for kiddos. He did have a decreased appetite at dinner last night. He did not want breakfast this morning, but he has had some sips of water. He did have a good void this morning, no stool yet, which is totally normal for him. He does not go to school or preschool like we said, but he plays on a soccer team with other kids. He has woken up 1 or 2 times the last night just because of that sore throat, had some sips of water, went back to sleep, but no problems before that. Here are his vitals as followed: heart rate 92, respiratory rate 26, O2 sats 99, and BP is 88/65 on that right arm. Because he's a little bit bigger, we can get him to sit still so we can measure his muscles, right? And his temperature is 100.1 temporally. So things that we are assessing on him, I have these up here. They are just a tiny bit different because he came in with that sore throat, right? So I threw skin on there. So he is awake, alert, he is cooperative, eyes all look good, ears has no tenderness, palpation, canals look fine, TMs are pearly gray, he has no drainage in his nose, septum's midline, turbinates are visible and pink, they're not boggy. He does have erythema noted to his pharynx. There is white exudate noted on his tonsils. They are 3+ bilaterally. His teeth are age appropriate. His tongue is midline. He does have mildly enlarged cervical and sublingual nodes. Lungs are clear throughout, equal bilateral chest rise. Cardio is fine, regular rate rhythm, no murmurs. Capri feels good. Pulses are 2+. He does not have any rashes, lesions. Skin integrity looks intact, and we have appropriate turgor for him. So what are we doing for Charlie as far as diagnostics?
Throat swab.
Yep. What are we swabbing?
The white exudate.
Yes, and even if there's no exudate, you can still swab that. You want to send off both a rapid and a culture though. So when you have those two little fuzzy sticks, these itty bitty things, you can do those at the exact same time so that we do not torture poor Ryan anymore. So you would anticipate, right, that you would get that. Depending on where you work, there are places that if you come in with meeting certain criteria that you do not need an order for that, you just get to do it and the physician signs off on it or the nurse practitioner signs off on it. So what are 2 nursing diagnoses for Ryan?
Risk for dehydration.
Absolutely. And?
Risk for non-compliance.
Yep, that's a good one too. And then certainly right now while we're in the office, somebody may have said it too, but definitely a pain is a good one for this one as well. So I did risk for aspiration. I was trying to give something different and unique that we haven't maybe talked about before. Definitely risk for aspiration related to if he can't swallow very well, there's a good chance he's gonna, maybe choke a little bit, take whatever it is and get that into his lungs. We certainly don't want that. And then a risk for ineffective airway clearance secondary to inflammation, right? If that starts to get too big, it gets too angry, we may have a decreased airway that we want to be careful for things like that. How about some nursing interventions for poor little Ryan?
You can do the ibuprofen.
Yep, absolutely. What else?
Depending upon the culture, you can give him antibiotics.
And really, the culture is not going to give us anything, but the rapid could give us something for sure. The culture, only because you're not going to get the culture back for a couple days because it has to have time to grow and tell you what the bug is specifically. But yes, based on whatever your throat swab is, we can do antibiotics off of that. So I did get the order for ibuprofen for throat pain. Same thing for him, really. He can have Popsicle or Pedialyte, and then talk to Dad about, hey, when we go home and we're eating, let's make sure that, we're really taking small bites, we're chewing and swallowing well, because, this is what we would be worried about. So you report to Kara, who is the nurse practitioner who cares for Ryan. She is asking you to obtain the rapid strep for Ryan as well as the culture. You've done that, right? As this rapid is developing, you need to catch up on your charting because we all know that, that doesn't happen when you want it to. So as you are charting, the provider for Charlie, Dr. Smith, walks by and tells you he has determined that Charlie has left otitis media, though it, quote unquote, isn't that bad. He wants to send Charlie home with a watch and wait care plan. How do we feel about this? So you can go back to your chart, which I can try to find for you, but it would take me a long time to find it on these slides, right? So we have a 2-year-old, right, with a unilateral ear infection that, per mom doesn't seem as bad as before. So the doctor says, yeah, he doesn't eat antibiotics. We're just going to send him home to watch and wait. How do we feel about that? I'll tell you right now, it's kind of a trick question.
I mean, you can see how it develops in that time.
So typically, I would have no problem sending Charlie home as a watch and wait, right? Dr. Smith is only caring for Charlie, right? Dr. Smith has no idea what's going on with Ryan. So, I did, look at me. I did put this in here like I was supposed to. So here's the AOM chart, right? So we're greater than 2 years. We really have unilateral, it's not severe. So honestly, observation would be a really fantastic choice. But as we are chatting with Dr. Smith, our timer goes off and it says that Ryan's rapid strep is absolutely positive. So what is your next move as you're sitting here with Dr. Smith?
Go do a consult with the other doctor so they all are on board and know what's going on with both kids.
Yep, absolutely. And really you can just tell Dr. Smith, because this is Charlie's provider, right? Hey, wow, look, this pulled up. The brother is here too. We just have this positive strep test. So both the NP, Kara, and Dr. Smith have decided to treat their patients with antibiotics, which is really what we were hoping for, right? And this is, I put this in here because I feel like this is kind of a key thing. This is almost a lot of case management, which you do as a nurse, and you don't always realize that. These providers would have really no idea, what was going on with the sibling unless they specifically asked. And that's why it's so important that we are there to help catch things like this. So each child is given a prescription for a liquid PO amoxicillin at 90 mg per kg twice a day for 10 days. We are going to choose the higher one for both of them. That's not something you have to worry about, but it's a just in case at this point. So what education are we giving mom and dad regarding their care plan, their antibiotics, their treatment?
Carry it out till the end,
Yes.
even if they feel better.
Okay. What happens if poor little Charlie just hates the antibiotic and she just doesn't want to take it?
She has to have it anyway because it'll kill the bacteria, but if it doesn't complete, then she can get it back.
Yep, absolutely. And, some people do not like, I can't make my baby cry. Yeah, well, you have to. And that's where you can also talk about, sneaking it into a little bit of applesauce and, kind of finding ways to make it a little bit easier for them.
Also, you need to shake the antibiotics, and
Yep.
sometimes if they eat with them, so it won't upset their stomach.
Yep, perfect. Those are great things. I have some generalities on here. Of course, make sure that they're drinking fluids, make sure that they're voiding. You can talk about what that would look like for each kid. They may not eat meals. We want to have small snacks throughout the day. What are some things that either kid would need to come back? What's a sign or symptom that they would need to come back and be looked at again?
Worsening symptoms.
Mm-hmm. How about the fever? When would we expect that to go away?
24 hours.
24.
Usually within 24 hours of having that. So if we're 2 to 3 days later and we're still having fevers, we need to come back because something else is going on. And I put this on here too, right? So we need to come back if we're not taking enough fluids, right? This is a very generality for healthy children. You can choose to figure out what the minimum is based on their weight, based on their age. This is what I put. Mom and dad do not want to have mils per day, per whatever that they want on there. Charlie should probably have 2 to 4 cups. And that's, again, for a healthy kiddo, right? And Ryan should have about 5+. So making sure that you talk about what those expectations are, and you can figure out their true fluids, which I used to do. But sometimes parents don't remember that, and it's easier to just give them a general idea. Persistent fever, right, for over 48 hours after the onset of the antibiotics, for either one of them, right, because we're basically treating Charlie even though we're not sure if she has it yet. She's probably going to get it, and the antibiotics we're giving her are going to cover both that strep throat and that ear infection. If either one of them have drooling or really severe pain, they're going to need to come back as well. They are contagious until 24 hours after they begin the antibiotics. Don't forget to throw away the toothbrush, good hand hygiene, things like that. Would we be concerned if Charlie or Ryan began exhibiting a rash?
It could be a sign that they're allergic to the antibiotic.
It could. That's a very, very strong possibility. What about if it was just kind of only on their trunk and it was really rough to the touch?
Scarlet fever.
Right. Are we going to be concerned about that?
Not necessarily, because that is, and that's one of the things that goes along with tonsillitis.
Yep. Perfect. And the difference between, I would say, rash, and I think I do have this, I have this on the next slide, and I'll show you that in a second. So definitely talk about with mom and dad, risk factors for repeat AOM, right? If Charlie is laying down taking that bottle at bedtime, that's going to increase that. If anybody in the home smokes, things like that. And then we're going to want to talk about when to follow up with your primary care, and talk about the short and long-term goals that we've already kind of discussed, but you want to talk about that with mom and dad. So I put this on here just so you can kind of see the difference. Scarlet fever is that kind of weird, pinpoint all over the place rash versus the hives that you get that you'll be concerned about with any sort of allergic reaction. Hives is a big deal in in opposition to or versus a regular rash, because you can get a viral rash from some sort of medication, or you can get this scarlet fever type rash. Hives is a true allergy to something, and that means you need to stop, come back, be retreated, things like that. It puts you at a much higher risk for anaphylaxis, for repeat of whatever it was that you were taking. And you know, in the case of penicillins, there's a whole bunch of medications who are related to that also, you know, you kind of you're not using anymore because you don't want to risk the chance that you're going to have that anaphylactic reaction to whatever it is. So that is all I've got. Questions? Anybody? I totally thought this was going to take longer, by the way. Anybody have any questions? Anything they'd like to add? Nope, we're all good. Okay, it is 10:28. I am going to stop the video, stop the recording, and pause it. And let's come back at 10:40, and I'll have Dr. Sinclair come back and we can start on the review then, so we don't have to wait, okay? Good, questions, concerns?
Thank you.
Okay, stop the video and I'll see you at 10:40.
Were you done?
Yes, sorry, I was just texting you. We're coming back at 10:40 and then we can do the review.
Sorry, Rachel, I had you on mute. Were you guys finished?
Yeah, so we're coming back at 10:40.
Okay, cool. I'll stop this now.